Hello, I'm Anne Cockcroft. Welcome to this short video about our study of the impact of universal home visits on maternal health in Bauchi State in northern Nigeria. Maternal mortality in Nigeria is still alarmingly high, especially in the north of the country. Part of the reason for this, and why it's hard to do anything about it, is limited access to well-equipped and functioning maternal health services, especially for the most disadvantaged women. We sought to improve matters by changing the upstream factors we'd previously found to be associated with maternal morbidity in Bauchi. That's heavy work in pregnancy, domestic violence in pregnancy, lack of communication between spouses, and lack of knowledge of danger signs in pregnancy and delivery. Our cluster trial randomly allocated 2 wards of one local government authority to receive home visits immediately and 2 control wards to receive visits after a delay of 1 year. After 1 year, we compared maternal outcomes between women delivering in the intervention wards and women delivering in the pre-intervention or control wards. The 8,000 or so households in the intervention wards each received home visits from a woman and a man. Each pair of visitors covered about 300 households. They visited all these houses roughly every 2 months. The female visitors met with all pregnant women several times during their pregnancies. They asked about the pregnancy and especially the 4 known local risk factors. They shared information about these risks and they asked what actions the household was taking to reduce them. The male visitors separately visited the spouses of the pregnant women, often in the evenings, and shared and discussed the same information with them. The home visitors recorded responses to questions on Android handsets. These same handsets also helped them to share information. The handsets were GPS enabled, which meant we could track the location of every visit and check if the visitors really went to the households. After 1 year of intervention, we collected information from nearly 4,000 women with completed pregnancies. We found that significantly fewer women in the intervention wards had complications in pregnancy, and significantly fewer had postpartum sepsis. Not surprisingly, we also found significant improvement in all the targeted risk factors. Less women in visited wards continued with heavy work in their pregnancies or suffered domestic violence, and more of them communicated with their spouses about pregnancy and knew about danger signs. We did not find that women in the visited wards made more use of health services. They were no more likely to go for antenatal care or for institutional delivery. We think this supports our idea that the improvement in outcomes is due to changing the upstream risk factors. Our trial shows that helping households to take actions themselves can improve maternal health, even without changing access to health services. This is important in the many places that have high maternal mortality and poor access to good health services.